But welcome to another round of CRS virtual education. Tonight, I am lucky to have my program director give us a talk on robotic APRs. Dr. Cannon has been an awesome mentor this whole year, and working with her has been a total dream come true. It's sad that you're moving to Arkansas, but I'm glad that you get to spend some more time with Tom. Coming up here, I just wanted to send a quick reminder to everybody that we have our applications for the next leadership crew for the virtual education series that are out. The links at the end of the emails each week. So if you're interested, please apply. Applications are still open, but we're going to be closing them right around ASCRS. So with that, I'm going to give it away to Dr. Cannon.
Thank you, Stevie J. And you'll see we actually, knowing that we were going to do this talk on APR, Stevie J and I made a little video in the OR recently. So you'll see her in my videos too for the perineal portion of this. So I'm Jamie Cannon. I am the program director at University of Alabama at Birmingham. I have been here 16 years, but I'm making a change. So I'll be moving to University of Arkansas and starting there September 1st. But I'm primarily a robotic surgeon, so we're going to talk about APRs in general, but with a focus on the robotic technique. I transitioned to pretty much a completely robotic practice in about 2011. So since that time, this would be the way that we do all of them. So obviously you are all nearing the end of your fellowship year, so I hope you all have done a number of APRs by this point. But historically speaking, there was a time when rectal cancer was essentially considered an incurable disease. And then the procedure of an APR for the treatment of rectal cancer was first described by Dr. Miles, who was a British surgeon, in 1908. And he described the approach where you do the lymphadenectomy and the dissection from the abdomen, and then, of course, combined with a perineal resection in order to resect the entire rectum. Indications for an APR have certainly changed over time. Basically, when we're talking about patient selection and deciding who needs this operation, we're usually debating between, does the patient need a low anterior resection, a low anterior resection with an intersphincteric proctectomy versus an APR. The traditional teaching was that any tumor below 8 centimeters required an APR, which is certainly no longer the case. And even back in my general surgery days, I know I was taught that anything less than 5 centimeters required an APR, but I would say that that is not the case as well. There are really some definite indications for an APR, and that's if you have tumor that's invading the levators or the external sphincter. Obviously, if the tumor is invading the levators or the external sphincter, those have to be resected. And in that situation, you generally would not want to reconstruct anybody, so they would usually get an APR. And how do you determine that? So in this day and age, of course, all of our rectal cancer patients get an MRI, and that is really shows us the anatomy the best way. You can see the levators, the external and internal sphincter, and you can predict that invasion on the MRI. I will say, however, that I still think a digital rectal exam is, for me, the most important thing in determining whether or not I can reconstruct a patient. So if a tumor, regardless of the location of the tumor, if it feels fixed and feels like it's not mobile from the pelvic floor, or I can feel that it's growing into the sphincters, then that would be a patient that I would say requires an APR. Some kind of borderline areas are if on your MRI you see invasion through the internal sphincter, but not necessarily into the external sphincter, but it enters that intersphincteric space. For the vast majority of those patients, if it actually enters the intersphincteric space, they probably should get an APR just because your ability to get negative margins are going to be difficult. However, those are patients that, if they have a good response to chemoradiation, might be able to get a low anterior in the future. In determining kind of, whether a patient gets a standard low anterior, and by standard low anterior, with that, I mean, we dissect all the way down to the pelvic floor, we mobilize the rectum away from the pelvic floor, and then you have room to staple below the rectum in order to do your reconstruction, versus an intersphincteric proctectomy, where with an intersphincteric proctectomy, we take that dissection again down to the level of the pelvic floor. But if you can't get good enough margins so that you're able to staple distal to the tumor, then we do an intersphincteric proctectomy, meaning we dissect the internal sphincter away from the external sphincter, and then that's generally a pull through with a hand-sewn coloanal anastomosis. And again, if either of those are not possible due to tumor location or invasion, then we would do an abdominal perineal resection. Now, with an intersphincteric proctectomy, if you look at the literature, it suggests that about 75% of people will have what's deemed kind of acceptable bowel function, but 25% of those patients will actually not have acceptable bowel function, and then we'll end up going back and getting a completion APR with a permanent and colostomy. So those are things that you have to take into consideration. You probably would not want to choose a patient that already had poor sphincter function or already had bowel function issues preoperatively to undergo an intersphincteric proctectomy. So the technical aspects of the operation, in terms of patient positioning, obviously we need access to the pelvis. So all these patients are in a significant Trendelenburg. One of the nice things about the robot, if you have table motion, is that it tells you exactly how many degrees the patient is positioned in. So we've just standardized it to make it very easy for the operating room. For any pelvic case, we put these patients in 25 degrees of Trendelenburg, and then we do a left to right rotation. So we tilt them 6 degrees to their right, with the goal being just to let the small bowel fall away from the inferior mesenteric pedicle. The port placement I'm showing here is generally what I do for most pelvic cases, and this is what we do for all low anterior resections. And you can do this port placement for an APR. With this port placement, we'd be going from left upper quadrant to right lower quadrant. And the advantage of this port placement is it allows us to access the entire spinal flexure. You can access everything from mid-transverse colon all the way down to the pelvic floor. So clearly you can do an APR from this port placement. However, for an APR, because you're not doing an anastomosis and a reconstruction, a lot of times you don't necessarily have to mobilize the spinal flexure because you don't need that additional length. So you have other options for your port placement as well. When I place my ports for an XI, generally speaking, the XI is designed to have all of your ports in a straight line. And the way I think about it is that we can access everything on one side of that line. So you could also do a transverse port placement. So here, this would be an example of ports just going directly transverse across the abdomen, and you would bring the robot in and dock it looking towards the pelvis, and then you could conduct the entire operation that way. However, the XI is very forgiving, so we generally take into consideration where their colostomy is going to be. So obviously this is a permanent colostomy, so its placement is absolutely crucial. It's very important that all these patients are marked preoperatively and that you've decided where the best placement for their ostomy is going to be. And I will generally plan wherever they've been marked for their ostomy for that to be our 12mm trocar site. So that's where we will staple from. So this will be kind of my starting point in terms of then deciding where my other trocars are going to be. The XI is pretty forgiving, so you can modify your port placement based on where that colostomy is going to be. So for example, if that's where this patient was marked, we might choose to kind of go not quite the steep oblique from left upper quadrant to right lower quadrant, but kind of transverse, bringing this one up to give us maximum reach, and just sort of adjust these trocars as needed to, again, accommodate where that colostomy is going to be. As I said, marking is important. All of our patients are marked in both the supine position, or as you see here, as well as sitting up so that you can really see where their folds are. And the markings show our options for the ostomy site, as well as marking of their creases, as you see here, so that we know what the kind of no-go zones are to make sure that we don't get a colostomy in one of those sites. Because they're all going to get a colostomy, I'll generally start these operations with a cut down. So we'll start at where they've been marked for their colostomy and just incise the skin, and do a cut down, place our 12mm robotic trocar in through that site, get our pneumoperitoneum, and then choose where our other 8mm trocars are going to be. For instrumentation, I use the exact same instruments in every single case. So it's the same whether for an APR, a low anterior, or right colectomy. We just kind of standardize it, and so it's very consistent. That adds to OR efficiency. I always operate with 2 left hands, so I'm going to have 2 graspers in my left hand that I can then toggle back and forth between. So my number 1 arm is always going to be the small grasping retractor. I like this instrument. It has a lot of surface area, and it's very atraumatic. So it has low grip strength, but that means that I can grab the colon, I can grab the small bowel, and I can pretty much pull as hard on it as I want, and I'm not going to cause any injuries because it is atraumatic. And as this operation progresses, as you'll see in the videos, I generally use the small grasping retractor for my macro or gross retraction. So it's going to hold the mobilized colon or rectum. It's going to grab that redundancy and pull it away from the operating field to get it out of the way so that I can see where I'm working. And then my number 2 is going to be the fenestrated bipolar or the forced bipolar. I choose these 2 instruments because they have very opposite characteristics, so they complement each other well. The grasping retractor is a smaller instrument, and it's going to be better for your fine dissection, and it also has a lot more grip strength, so it will hold things more firmly. And then my right hand will be whatever my active dissector is. So I do the vast majority of the pelvic dissection with scissors, so that we're doing a sharp dissection, not a blunt dissection in our TME plane. And that's also where my vessel sealer will be and where my stapler will be. So the beginning of this operation is just like a low anterior resection. Obviously the proctectomy, your TME is done essentially the same way until you get to the distalmost aspect of the dissection. So we're going to start with a mesenteric dissection. We're going to do a medial to lateral dissection. So we'll start by reducing the redundant rectosigmoid out of the pelvis and placing the mesentery on some tension so that we can see the course of the inferior mesenteric pedicle. And then we'll score the peritoneum overlying the pedicle and dissect the IMA off of the left retroperitoneum, making sure that we identify the ureter. So we'll look at that in some of these videos. So here's, we're starting, you see my bipolar, I just kind of lift it anteriorly to get it out of the way. And then my grasping retractor is going to hold the redundant rectosigmoid up and put the mesentery on some tension so that we can see where the IMA is coursing. And then I'll come down with my bipolar. So we can see here where the IMA is running. I lift that up with my bipolar, and then we're going to score the peritoneum underneath the IMA and find our plane. You want to be careful that you're staying right underneath the IMA. You can see that the pointer there kind of showing where that plane is. This fatty tissue here contains the nerves coming from the lumbar plexus that we want to try and preserve to the extent that we can. So we should see this nice shiny surface right underneath the superior hemorrhoidal artery that we're dissecting underneath. And here you can see the ureter there just came into view. So we'll dissect the ureter away from the IMA and continue dissecting towards the origin of the IMA until we're ready to divide it. So right now with my scissors, you can see that fatty tissue that's near the origin of the IMA, which is generally fairly vascularized. So we dissect that out and cauterize that until we're ready to divide the IMA. And then we'll take the IMA with a vessel sealer, as you're seeing here. Once we've divided the IMA, I generally continue to work with the vessel sealer. I think it does a really nice job for blunt dissection. So here we're lifting up the mesentery of the sigmoid colon and pushing gonadals and ureter will be running in this tissue, pushing the retroperitoneum down as we continue to dissect the descending colon and the sigmoid colon off of the retroperitoneum. And we will look at that one more time. So this video is showing the exact same thing. The only difference in this video is that in this particular case, the patient, for whatever reason, had a cystoscopy preoperatively. And so we asked urology to inject some ICG in the ureteral orifices. So that lights up the ureters, excuse me, with the ICG throughout the course of the case. So it helps save us a little bit of time in identifying the ureters. So here we can see the ureter running here. And when we look with Firefly, you can see the ureter nice and green and makes it very easy to identify. As we're developing this plane, right now we're in the proximal aspect of the rectum. So that's the beginning of our mesorectal plane in the posterior position. And then here we're at the root of the IMA. So once again, opening up that peritoneum and then this fatty tissue that's along the IMA in order to get it dissected out at its origin. And just another look, the pretty ICG in the ureter. And then once again, once we have the IMA dissected, we'll divide that with a vessel sealer. Once the IMA has been divided, I'll generally get my grasping retractor down here to hold up the redundant mesentery that we've already divided. And then my bipolar will come underneath, and I'm identifying that junction right between mesentery and retroperitoneum, and my bipolar will tent that up. And then my vessel sealer will push the retroperitoneum down, and we continue to work out laterally underneath the sigmoid colon to develop that plane, and then continue to work up towards the head, up towards the inferior border of the pancreas, in order to work up towards the transverse colon and get the colon completely mobilized. Now, for an APR, this mobilization does not have to be as extensive in terms of how cephalad we go, because again, you don't need that additional length for creation of anastomosis like you do in a low anterior resection. Once the medial dissection is done, then we'll rotate the sigmoid colon to the right, so we're pulling it away from the lateral attachments, and then we will divide the peritoneum and hopefully enter that plane that we have already that's already been dissected out from our medial dissection. So here we're pulling the colon medially. You can see where the peritoneum is attached to the colon, incising the peritoneum and entering the plane that we already developed from the medial direction. And using the scissors to continue just to divide that peritoneum. You can see my bipolar here is not actually grabbing the colon. It's just reaching around it and hooking it and pulling it medially in order to create tension. and see where the peritoneum needs to be divided and where it joins with the dissection that we did already. And we'll generally continue that just as proximal on the colon as is easy. Again, don't generally have to take down the entire splenic flexure since we don't need that for length. And once the colon's mobilized, then we'll go to our pelvic dissection. We'll do a standard TME again, like the low anterior resection. My preference is to start with the posterior dissection because that's usually easiest. We'll complete the posterior dissection as low as it's easy to do and go up on the sides as much as we can from the posterior approach, then divide the lateral ligaments and then open the anterior peritoneal reflection. And we'll continue that dissection and circumferentially down to the level of the pelvic floor. Once you start to get close to the level of the pelvic floor and you reach this distal portion of the transection for an APR, then this is where you have to decide if you're going to do essentially a traditional APR versus an extra levator extraction. So, and just to kind of go over the differences between these. So a traditional LAR, we follow, you can see, so here's your mesorectum, around the rectum, the fatty tissue of your mesorectum. We follow that down as it enters the pelvis. And then, like you would in a low anterior resection, you dissect the mesorectum off of the levators, dissecting them away from the levators until you get to the point where you want to divide the levators. And then you can just come directly through them as you see here. APRs are associated with a higher rate of local cancer recurrence as well as a higher rate of tumor perforations as compared to a low anterior resection. Because of that, the idea of an extra levator extraction was proposed. And what that means is that instead of dissecting your mesorectum away from your pelvic floor like you normally would, you stay all the way out on the walls of the pelvis, so that you come down here and the entire levators are extracted. So you divide the levators rather than dividing them somewhere here in the middle, directly off of the walls of your pelvis. The idea behind that was that it prevents any coning in on the rectum, and with the hope that that would decrease your rates of local recurrence and your rates of tumor perforation. However, I will say that if there's no tumor in this area, there's really no reason to sacrifice good healthy levators. The less levator that you have left, the higher your incidence of wound complications is going to be, because that is healthy, well-perfused skeletal muscle that can help that area heal and help fill some of that space. I think that the reason that we see higher rates of tumor perforation and higher rates of local recurrence with APRs is that by definition, if a patient is getting an APR, these tend to be more advanced cancers. And actually, there was a large study done that had the highest number of patients, a database study that showed that doing the extra levator extraction does not necessarily reduce your rates of tumor perforation or local recurrence. So while I would agree that it is sometimes necessary to take the levators, depending on your tumor location, we can use our MRIs as well as your digital rectal exam to help determine exactly where the tumor is. And it's perfectly acceptable to take the entire levator on one side, but then preserve the levator on the others. So we can tailor this operation to our tumor location to make sure that we get negative margins, but that we preserve as much levator as is possible. So what this looks like, so this is just showing a TME. What this is showing here is we're starting the posterior dissection. At the beginning there, you saw the hypogastric nerves running, and you could see the fatty tissue that often runs along those nerves and can help you identify where those nerves are. And so this is the posterior plane. We're tenting up on the mesorectum. So here's your mesorectum, we're lifting it up, and you can see that very nice embryologic plane with that filmy tissue that we are dividing. You want enough tension as you're doing this dissection so that when you cauterize, those tissues should separate. But you want to make sure that you're doing this sharply with electrocautery or with scissors, not via blunt dissection. So as you're tenting up, the tissue should not be tearing. You want to make sure that you're actually dividing them with your scissors or with whatever cautery device you're using. And there you saw dividing the right lateral ligament. And then here we're opening up the anterior peritoneal reflection. So this particular video is in a man. So you're seeing the prostate starting to come into view here. So we're identifying that plane between the prostate and the rectum and dividing that plane. In most patients, you want to leave the prostatic capsule intact. You can see the nice shiny surface on the prostate. He has a very large prostate here. Now, if the patient has a tumor that abuts the prostate or you're concerned about a positive margin there, you can take the prostatic capsule along with you. But if you do that, you will by definition have nerve injury if you take the prostatic capsule along with your specimen. So here's another example. So pelvic dissection, my grasping retractor is coming in, it's coming underneath the mesorectum, and it's pulling our mobilized rectum up and out in order to get that redundancy up out of the pelvis. And then my bipolar is coming down and it's giving me additional anterior traction so that I can see these planes where we want to divide. So the bipolar is giving me that traction. Our planes become visible. Your right hypogastric nerve is going to be somewhere in this fatty tissue here. And so we're dissecting that away from our mesorectum. And then continuing that posterior dissection down into the pelvis. And we can see here now as the rectum starts to come anteriorly, as we continue that posterior dissection, following it anteriorly. I like to do as much as I can from posterior. So here we're on the left pelvic sidewall, and I'm going to continue to mobilize the mesorectum away from that left pelvic sidewall, and that will make our division of the lateral ligaments much easier. And once we've done that posterior dissection, now we're pulling the rectum out and to the patient's left and dividing this peritoneum. You can see the nice plane again between the mesorectum. As we do these the lateral sides, you want to be cautious that you don't come all the way out here. It's very easy. This particular video is in a woman, but the seminal vesicles would be in this area in a man. It can be very easy to get around the corners of the vagina or around the seminal vesicles because there is a nice plane out there. But you want to make sure to avoid that and staying closer to your mesorectum, again, to avoid nerve injury. I find that sometimes it helps making sure that you don't get too lateral if you divide the anterior peritoneal flexion somewhat early to make sure that you're staying in that appropriate plane. And again, that we're not going out here. We're going to divide that peritoneum and stay directly right along our mesorectum. When we're ready to divide the anterior peritoneal flexion, my grasping retractor is pulling the mobilized rectum out and directly back so that we can see where the true anterior peritoneal flexion is. We'll divide that peritoneum until we get down and are able to see a little bit of areolar tissue between the vagina and the rectum. Some patients will have will have some bulk of mesorectum in this area, while in other patients, the vagina and the mesorectum will be right on each other without really any fatty tissue. Here you can see the plane nicely, the anterior mesorectum and this areolar plane as we develop that and dissect the vagina away. And then again, so now we're just distal to the anterior peritoneal flexion, doing a vaginal exam to help identify where the vagina is. And now in this particular patient, they had a very close margin between the rectum and the vagina. So we're feeling where that tumor is in order to determine where that is. Here we're down at the level of the pelvic floor, and so you can see the levators here, and you can see that we're just coming directly through the levators. As I discussed with the robot, the visualization is excellent, and you can really tailor this as to where you want to divide the levators. This is the anterior dissection, and I mentioned we had that close margin. So here where we have that close margin, we're entering the vagina, and we're leaving a rim of vagina on the rectum in order to make sure that we get negative margins in this area. So we've incised the vagina, leaving this tissue where we're concerned about a close margin on the rectum. And again, this is part of the beauty of doing this robotically, is that it really allows you to do a precise dissection and again, tailor it to tumor location and the patient's pathology. So now that the vagina is left on the rectum, now we're trying to reestablish that plane. So we mobilized the rectum and vagina a little bit and got back into the normal plane as we're now distal to where we were concerned about tumor location. And now here's the vaginotomy. And with the robot, we can easily repair that vaginotomy primarily. So that's what you're seeing here. We're using a V-lock to repair that vaginotomy. And then once that's done, then just continue our dissection. Right there, you saw we just flipped the camera from 30 up to 30 down, which can really help show you these last posterior attachments. So here we're starting to get distal to the coccyx. We're dividing the anococcygeal ligament. We've already divided part of the levators, and we divide the anococcygeal ligament and connect essentially where we've divided the levators on the left and the right. And here we're on the right side, again, dividing the levators on the right. In patients with favorable anatomy, you can often get all the way through the levators and down into your ischiorectal fossa and into that fat. Once the pelvic dissection is done, then what you're seeing here is we're just coming up deciding where we're going to transect the colon for creation of our colostomy. We divided the mesentery right up to the level of the colon and then just stapled across the colon so that the rectum is on the proximal side now completely free. We then place a locking grasper on the staple end of the colon that will eventually become the colostomy. And then at this point in the operation, the robotic portion would be completed. So we would generally go and once the robotic portion is done, then we'll undock the robot. We will exteriorize the proximal side of the colon, go ahead and create our colostomy, and then turn our attention to the perineal portion of the operation. And so this is another video, once again, showing the pelvic dissection. So same thing here. In this case, so with our grasping retractors holding the redundant rectum out. Bipolar is again getting us that anterior tension. You can see the left hypogastric nerve running right along here quite easily, and we're dissecting that away from the mesorectum there. And there is our nice posterior plane that will continue to develop down to the pelvic floor. And I mentioned before that I find that it's sometimes helpful to open your anterior peritoneal reflection early. So that's what you saw here. We marked out exactly where our anterior peritoneal reflection was and opened that up. And then dividing our lateral ligaments on either side down to the level of the anterior peritoneal reflection. As we switch over to do the left side, my grasping retractor is grabbing the rectum, pulling the redundancy out and retracting it towards the right. And then we're coming down, dissecting the mesorectum off of the left pelvic sidewall there and getting that to come and communicate with where we've already opened the anterior peritoneal reflection here. And developing that plane between the rectum and the vagina. There we can see the levators kind of coming into view on the side there. Here we are anteriorly again, continuing that plane. And taking it off the right pelvic sidewall there. Those last attachments again, the grasping retractor holding the rectum up and anteriorly, and then bipolar coming down to see these posterior attachments. As we're mobilizing it away from pelvic floor, here you can see the levators. And your anococcygeal ligament with those last posterior attachments. Just some things. So in women, obviously, unfortunately, the uterus frequently gets in the way, and this is just demonstrating our technique for managing a uterus that is floppy and kind of laying in our way. You can see we bring a Keith needle from the suprapubic region. Bedside assistant will bring that in place, and then I bring it through the broad ligament on the right side of the uterus, and then underneath the uterus, and then up through the broad ligament on the left side. So it's not going through the body of the uterus; it's going through avascular planes. So your incidence of bleeding should be very minimal, and it just essentially then acts as a sling underneath the uterus. Once that stitch is placed, I'll hold the uterus up and get it positioned where I want it, and then my bedside assistant will tighten that up and put a hemostat on it in order just to hold it there through the remainder of the case. A similar concept. This particular video is from a morbidly obese man with a very narrow pelvis where we're really struggling with visualization. And with his obesity, the bladder and anterior peritoneal reflection kept falling into our face. And it was requiring either myself or my assistant to retract that up the entire time. So in order to save us one of those retracting arms, we just put a stitch through that and essentially pexied it to the anterior abdominal wall. You see here, a very difficult pelvis, narrow, a very obese mesorectum, a very thick mesorectum, and so very little working space. But what you're seeing here is just guiding the camera, the suction, and the scissors down into that little space. And the obese patients with the narrow pelvis, these cases are always exceedingly difficult, and it adds a lot of time to the case. But the ability to kind of guide your camera down and work in a very small space, you can do that and then just make your way around so that you can actually visualize these attachments. These difficult cases in the obese patients are ones that if you were trying to do these open, you'd probably be doing them mostly blind. But using the robot allows us to, as I said, guide the camera down there and actually see and actually look down there. So once the abdominal portion is done, then of course it's time for the perineal portion of the operation. When this surgery was first described, it was actually described as doing it in a left lateral decubitus position, although I don't know of anybody that does that today. But these can be done either lithotomy or prone. Lithotomy is my preference, and that's for an efficiency standpoint. So when you do it in lithotomy, they're positioned in lithotomy from the very beginning of the operation. So there's no repositioning the patient, flipping them over, moving them over. And while we don't usually have the luxury of having a two-team approach, if you happen to have another surgeon that's working with you and you do have that luxury, if you have them positioned in lithotomy, the perineal portion of the operation can be happening at the same time as the abdominal portion. There are a lot of people who like doing this operation in prone, however, and that's certainly a reasonable thing to do. Of course, that does mean after you finish the abdominal portion that you then have to reposition them in the prone position. But the advantages of doing it in prone position are your visualization is better, and it also allows better access for your assistants. So you may have more people that are able to retract and provide exposure as you continue the operation. As Stevie J will know, as a robotic surgeon, my goal is always to do as much from the abdominal portion as is possible. Even though I'm a colorectal surgeon, I don't like being squeezed in between the legs. And so we generally really try and do as much from above, with the goal being to just have a minimal amount of perineal dissection required once we get down distally. And so again, we do that all in lithotomy. So we start the operation by initially making the skin incision. So we're going to come through here. We're going to come around the anus and come through the skin. So all patients will have little perforating muscle fibers that go from the external sphincter to the skin. And those little perforating muscles are what's responsible for the anal wink reflex. So when you first start the operation, you're going to come through those very superficial muscle fibers, and then you should reach adipose tissue. And at that point, you're going to identify kind of where your external sphincters are, and you continue the operation going just right outside of your external sphincters. So the ischiorectal fat, you're separating essentially the external sphincter from the ischiorectal fat, and you follow that up until you reach the levators. The videos that I'm going to show here for the perineal portion, we're actually just using a Gelpi retractor because this patient had fairly favorable anatomy, and so retraction was not difficult. And we had done a lot of the operation from the anterior approach. However, in the vast majority of patients, we do use a Lone Star retractor. So I think Lone Star retractors are ideal. We generally use a circular Lone Star retractor, and we use a total of 8 hooks to retract the perianal skin and provide good exposure. But so generally speaking, we always enter to communicate with the abdominal portion of the operation from the posterior approach. So you saw in the videos before, we divided the majority of the anal-coccygeal ligament anteriorly. When you're doing the perineal operation, as you're working, you should be reaching in and periodically feeling where the coccyx is. You want to make sure that you don't get posterior to the coccyx, which is an easy mistake to make. But you should be feeling where the coccyx is, and you should essentially be aiming just directly anterior to the coccyx. And if you're doing that, you should then be able to enter where the abdominal portion of the operation is. So we keep dissecting in that, aiming towards the anterior portion of the coccyx until we're able to kind of poke through and feel with the finger, as you see here, where they communicate. Once we have communicated with the anterior portion of the operation, you can then hook the levators and divide them wherever you want, whether that's out laterally or closer to the rectum. So here you can see finger going in, and so that finger is coming and hooking the levators. So Stevie J is here, putting them on some tension, pulling the levators down towards us, and dividing the levators. I'll do that on either side, both the right and the left, and so then that gives us a pretty large defect where we've communicated with the anterior portion of the operation and just had the anterior dissection left to do. And then, so here you see Stevie J taking down the vagina off of the rectum as we continue the anterior dissection. If you can see that plane well, you can continue it just like we are here. And if your anterior dissection was very low, you can often just kind of place a finger like you did with the levators and sort of hook above the vagina where you've dissected it out as she's doing there. And then you can see that plane very nicely. In some patients, it can be difficult to bring that into view, particularly if you haven't done as much from an anterior approach. And in those cases, we'll divide the levators all the way on either side, and then the anterior portion of the operation can be easier if you actually exteriorize the rectum. So if the anterior dissection is a struggle, that is one option, is to pull the rectum that's already been divided and bring it out posteriorly so that the majority of the specimen is hanging out and it's only still attached by that anterior portion. And that can allow you to really bring it to you and deliver it towards you and complete your anterior dissection. And then the last video I'm going to show today is, of course, the funnest part of the operation. So here we've got Stevie J pulling the rectum out at the end of the APR. Very satisfying. And so once that's out, then, of course, then you have to decide how you're going to close your perineum. I generally do a primary closure. I do a primary closure in the vast majority of patients, unless the defect is just too large or you had to remove a lot of skin. I find that in the rare circumstances where we have to do an APR for squamous cell carcinoma, it's much more common that a primary closure is not sufficient. Those patients have obviously been radiated for a long period of time. They're usually large tumors, aggressive tumors, when they don't respond completely to the radiation and all their tissues are fixed in place, and you frequently can't get anything to come together in those squamous cell patients. But for the vast majority of adenocarcinomas, we generally will close those primarily. And the way I do that is whatever levators are left remaining, we put interrupted vicral sutures through the levators, and then we bring whatever soft tissue we can to kind of try and help close that dead space, and then just close the skin primarily. However, the most common complication that you see after an APR is wound issues of the perineal wound. I would actually argue that that probably shouldn't even be described as a complication, but more just as kind of part of the operation. Sometimes they do heal beautifully and you don't have any perineal wound issues, but it is very common for those incisions to separate and for some wound care of the perineum to be required for some period of time. However, because of the morbidity associated with a lot of the flaps, I generally will accept that there will be some dehiscence of the perineal wound, and I would choose to manage a perineal wound over the consequences of having to do a larger flap. However, if those wounds don't heal, or in cases where the defect is just too large and you really need some other tissue down there, there are a lot of different options. So obviously you have the VRAM. So that's where you take one of the rectus muscles and bring it down to fill in that dead space. The advantage of a VRAM is that particularly if you have a skin defect, or also in women if a partial vaginectomy was required, you can leave the skin on the flap and do a myocutaneous flap so that the skin can actually reconstruct the posterior wall of the vagina as well as the pelvic floor. This can be done with gracilis as well, although gracilis has a significantly less bulk than a VRAM, which is why those are generally the preferred flaps. And becoming more popular are also gluteal advancement flaps, where you actually do like a VY flap and you mobilize the skin and subcutaneous tissues off of the gluteus and mobilize it into the wound and then close the donor site primarily. And the advantage of a gluteal advancement flap is that you're not creating then any abdominal wall hernia. So you're not taking that muscle that's used elsewhere and bringing it down into that incision. Obviously, gluteal advancement flap would require this to be done in prone position. And so that's really all I have for you guys this evening. I put up my email address there. Please feel free to email me. Most of the videos that I showed here today are on my Dropbox. So if anybody wants access to the Dropbox, it's also got videos for other operations as well. You can send me an email and I'm happy to share that with you. And then I think Stevie J, you had some questions and some things to discuss. So I'll turn things over to you.
Yep. Thank you again for doing this. Really appreciate you being here, especially on a holiday weekend. Couple questions from the fellows. So the first one, just kind of piggybacking on talking about complications and wound complications. Have you ever had to deal with a prostatic urethral injury? And if so, what did you do?
I'm actually glad you brought that up because I forgot to discuss some things that you need to think about when you're doing this operation to try and avoid a prostatic urethral injury. So I would say that this is the most devastating complication associated with an APR. because all of these patients have had radiation. And so if the prostatic urethra is injured, unfortunately, they just don't heal well. And reconstruction is very, very difficult. And yes, it's devastating if you see a patient and then they have urine, coming out their perineal wound later. So obviously, first way to avoid this complication is to avoid it to begin with. So I discussed for the perineal portion of the operation that we want to stay outside of the external sphincter. So you're dissecting outside of that muscle. The exception is in the anterior plane. So in the anterior plane, you have the transverse perineal muscles, and that's kind of where your perineal body is. You will actually do this through the perineal body. And this is the one case where you don't want to go outside of those muscles unless you have tumor that's actually invading that area. And if you preserve the transverse perineal muscles, then you should not get a urethral injury in this location. So that's very important. Obviously, you have a Foley in all of these patients. As you're doing the dissection in men, you can kind of palpate and make sure that you're not feeling that Foley, that you're not getting too close to it. That being said, there are going to be some circumstances where this does occur, unfortunately. Obviously, if you know that you have a close margin towards the prostatic urethra initially, you can get urologists involved to try and see if there are any options. Obviously, those patients will often require an anterior pelvic excineration, and then they'll be getting an ileal conduit. But once you have that injury, again, reconstruction can be very, very difficult. Management of that, you're going to start with generally diversion. You'll, of course, have a urologist involved at that point, but they'll often place a Foley as well as do a suprapubic diversion. And then there are a number of different techniques you can consider down the road to try and get the urethra to heal. But when they're radiated, unfortunately, these are just not always successful. But the key part of managing that complication initially is with urinary diversion.
And then any tips for management of perineal hernias?
So perineal hernias are difficult to repair. The vast majority of perineal hernias, fortunately, don't require any repair. So when we see these patients for surveillance, we always check them for a perineal hernia, and sometimes we do encounter them. But as long as they're not giving them problems, we generally leave them alone. Repair of these is a pretty large undertaking. And so again, if the patient's managing them okay, we leave them alone. The circumstances where they do require repair is if they just continue to enlarge and they stretch the skin out so much that you just essentially kind of have skin over bowel and you get this bulging down in the perineum. If that skin gets attenuated, or if they find that they're just kind of sitting on their small intestine, then in those situations, you usually do have to fix them. Fortunately, because it is a rare complication, I don't have a lot of experience fixing them myself, but I do find it to be challenging. On the few that I have repaired myself personally, I've used a biologic, and I go in robotically, we dissect all the small bowel out of the pelvis, and then when you're looking at the pelvis, we'll lay a biologic across kind of what used to be their pelvic floor. The challenge is trying to find what to attach it to, because obviously in these situations, their levators are pretty much gone. And so I don't know the right answer to that. It's kind of just trying to find what your most substantial tissue is down there and find something to attach that to. But this is something I would not hesitate, particularly if it's difficult, to get a plastic surgeon or somebody else involved to come and help you with that. Although I've found that they do things very similar to the way we do, and they have the same challenges that we do in terms of trying to find something substantial to attach it to down the pelvis. This would also be a circumstance where if the patient did not get a muscle flap initially, you could also help the situation. You could consider doing a VRAM. You could put that down on the pelvis and then even lay your biologic mesh over the top of that as well, just so that you've got some more substantial tissue there.
Awesome. Thank you. And I guess pre-operatively, if you are thinking about getting plastics involved, when do you send patients to them? And I guess how often do you feel like plastics is needed?
So as I talked about that a little bit, that every colorectal surgeon will probably have a different opinion. I very rarely plan for a flap from the very beginning, for the reasons that I mentioned. The flaps have their own issues and their own long-term functional consequences for the patients, high rates of incisional hernias. And so I don't do that routinely. As I said, I'd rather kind of deal with the perineal wounds than the problems associated for the patients with the donor site. But yes, there are some patients that you just don't anticipate that you'll be able to get closed, and then I would absolutely have them see plastics preoperatively. I don't know that there's any specific time frame. I would say that as soon as I evaluate them after the completion of their chemoradiation, if I've determined that they are going to need plastics, I would try and get them in with them right away so that we've got some time to schedule a joint operation.
Okay. Those are all the questions I have from some of the fellows, and let me check the chat really quick. And looks like that's it for today. Thank you again for being here tonight. Also, another plug for people to apply to take over for leadership for next year for the virtual education series. And again, happy holidays. Stay safe, everybody. Dr. Canyon, thank you so much for doing this tonight. Great talk, and we really appreciate you doing these every once in a while. Oh, I'm sorry. Somebody just posted one question. What's your protocol for ICG for the ureters?
Oh, that's a great question. We do not use it routinely. The reason being that there is not really a way to do it without requiring a cystoscopy. And so that's an added procedure that has its own potential pitfalls, and then also adds time in the operating room. So we do not use them routinely. If there's a patient that I suspect might need a ureteral resection, and I know we're going to be really close on the ureter based on their MRI and the tumor location, that would be somebody that rather than ICG, we would probably put stents in so that we know if we have gotten into the ureter and that they're going to need a reconstruction. So generally speaking, we just use our anatomy and identify the ureters and dissect them away. But I showed that video with the ICG and the ureter. I do love those videos, and I think it helps speed things up if you can use that to identify them. So if a patient is getting cystoscopy for one reason or another, then I would absolutely just take advantage of that fact and use the ICG. And there are basically two different ways that you can use ICG. You can place stents, and then the ICG can be injected through the stents. But if they don't need stents, you can also just inject the ICG up into the ureters. So generally that's 3 cc. People may have different protocols, but usually that would be 3 cc's of ICG in each ureter prior to the start of the case, and that will light them up green for the entire case. I will say that I have been told, I've been told this for years, that there is an ICG that has been developed that's renally metabolized. It's been undergoing apparently FDA approval for some period of time, but I've been told that we will have it available to us in 2025. So when we do have that, I'll be very excited about that, because that means that in pre-op, you could just inject the ICG preoperatively, and then it's renally metabolized, and so it can light up your bladder and ureters during the course of the case. So when that is available and we can light up the ureters without having to have a cystoscopy, then I would use that every single case.
I did not know that was coming. Awesome. If there are no other questions, then we'll finish a little bit early and let everybody enjoy their holiday. A lot of comments on your videos. Thank you for having them. And again, we really appreciate you being here.
Thank you. Thank you for the invitation.
All right,
Fun to do.
have a good night.
All right. Take care.